Okay, so I'm going to cover from Dr. Quadri's gonadal hormone lecture up until the antiviral lecture, and then on Wednesday night I'll cover the last four. That way, one, I don't hog too much of your guys' time since I know you have, I think, OPP, EPC exam coming up first, and then also because I'm trying to keep up with my board studying schedule. Okay, so everybody's good. We'll go ahead and get started here. Okay, so starting with the pharmacology of gonadal hormones. Uh, so I included this slide. It's just a good slide to keep track of where all the drugs are working in this lecture. And then we'll start here with the difference between GnRH agonists and GnRH antagonists. So with initial overstimulation of GnRH receptors, this is going to lead to an increase in LH and testosterone production. And this is referring to the pulsatile release of GnRH. So one of our GnRH analogs is leuprolide. So this would be referring to leuprolide. And then a chronic administration will eventually lead to suppression of LH, resulting in suppression of testosterone. And this is referring to the continuous release of GnRH that you see with leuprolide acetate, which is the depot form. So if you guys are familiar with, the Depo-Provera shot, the birth control shot, kind of works in a similar way. And then our GnRH antagonists are going to have an immediate onset of action. So you get, an immediate antagonism of GnRH leading to a decrease in FSH and LH. And this is beneficial because when you're giving it in the continuous administration, like the leuprolide acetate, you initially see that testosterone flare. Which you got into, why that's dangerous. Okay, so our GnRH analogs, our GnRH agonists, when they're released or given in a pulsatile fashion, GnRH is going to increase LH and FSH. However, when you give them in a continuous fashion, it's going to turn off GnRH and decrease LH and FSH. However, this is eventually, because initially you're going to see that initial flare of testosterone due to an initial increase in LH and FSH. So we have leuprolide and then leuprolide acetate. So leuprolide is referring to the short-acting version or the pulsatile release, which is going to increase LH and FSH. And this is used for ovulation stimulation and then in vitro fertilization. But the one I would definitely focus on for this exam would be the sustained release. Which I don't even think he is going to test you over the difference between leuprolide and leuprolide acetate. So just as long as you know that leuprolide in the sustained released form is going to suppress LH and FSH after initial flare, you'll be fine. So this is used in palliative care of prostate cancer and then also breast cancer and precocious puberty. The use I would focus on right now would be palliative care of prostate cancer. But what is precocious puberty? What does that mean? Right, yeah, just a very early onset puberty. So if you have like like an 8-year-old female that's presenting with like, or, like 7-year-old female that's presenting with like breast buds and pubic hair, that might be considered precocious puberty. So you can give something like Leuprolide to prevent that early onset puberty. And then some of your adverse effects with Leuprolide are hot flashes, gynecomastia, and that's due to the fact that you're messing with the ratio of testosterone and estrogen. So you're going to see, decreased testosterone, and then a higher level of estrogen. So due to that estrogenic effect on the breast, you're going to see like increase in breast tissue, so gynecomastia. Also, you can see osteoporosis and decreased libido and venous thromboembolism. Okay. Our GnRH antagonists, these are the relixes. So if you see anything in relix, you can know it's a GnRH antagonist. And I think the one to focus on is going to be Degarelix. And Degarelix is going to reduce the concentration of testosterone more rapidly than a GnRH agonist, and it's going to avoid the testosterone surge seen with a GnRH agonist. So with Degarelix, you're not going to see that initial testosterone flare. And this is used in the treatment of prostate cancer as well. Okay, and then your other two relixes, you really didn't stress these or have anything in red about them, but maybe just be familiar. Okay, so our testosterone receptor antagonists, these are flutamide, bicalutamide, and nilutamide. And these are used in the treatment of metastatic prostate cancer, and they're going to prevent that initial flare that you see with leuprolide acetate depot. So you can give leuprolide, so kind of the take-home point here is the fact that you can give leuprolide acetate to suppress the the LH and FSH, and then also tack on flutamide to prevent that initial testosterone flare. So testosterone flare is referring to the rise in testosterone that's caused by an initiation of an LH-RH agonist, so like leuprolide. And you'll see an initial increase in testosterone and estrogen from GnRH analogs, and that can lead to a temporary increase in risk of thrombosis. It can also drive rapid growth of small tumors during metastasis and lead to cardiovascular crisis. So the solution here to prevent that testosterone flare, which can be dangerous, is to combine a GnRH analog with an antagonist like flutamide or bicalutamide, and for the first month or two. Would these drugs always be given with leuprolide? Like you wouldn't give them on their own? That was my understanding, is that you would give them in addition to leuprolide to prevent the flare. But that's just my understanding from his lecture. Yeah, I mean, I'm not 100% sure if you could give them alone, but he acted like it was kind of like in addition. Because the testosterone flares, it's dangerous because it increases your risk of thrombosis and then also growth of small tumors. All right, so our 5-alpha reductase inhibitors, the one to know is finasteride, and it's going to block the formation of dihydrotestosterone and abrogate or fancy word, I guess, for just get rid of the local action of testosterone. And this is used in benign prostatic hyperplasia. And kind of a big thing to know here is that pregnant women should not handle these tablets. So, if you have a patient, with a partner and he's being treated for benign prostatic hyperplasia, it's probably a good idea to inform him that if his partner is pregnant or becomes pregnant, that she should not handle these tablets, and that's due to just the risk for teratogenic effects. And then also another common scenario is make sure you don't ask your pregnant nurses to give patients finasteride. Okay, so gonadal steroids are ketoconazole and spironolactone. I don't think he'll test you on these, at least not in the context of this lecture, just because we've covered them so many other times. But from my understanding, 1720 desmolase is just another name for 1720 lyase, if you were confused like I was. Okay, so with your effects of estrogen, go ahead and kind of read and acknowledge the non-starred ones. But what they're going to focus on as far as the exam goes, or at least just from experience, what they focused on, I guess I should say, is the 3 that are starred. So with estrogen, you're going to see an increase in endometrial proliferation, and then also prothrombotic effects, and then induction of osteoclast apoptosis. So this is helpful so estrogen, like for example, estrogen replacement would be helpful in either treating or preventing osteoporosis in patients. So definitely focus on those 3. And this kind of ties into your adverse effects of pharmacologic estrogen. So one big one is the risk of thromboembolism. So estrogen, actually, never mind. So thromboembolism, and then also estrogen is category X in pregnancy. Do you guys know why that is? Yeah, that is a possibility, but there's kind of a bigger reason. So it's because pregnancy is a hypercoagulable state. So if somebody is pregnant, they're already at increased risk of DVT. So by giving them pharmacologic estrogen, you're increasing that risk. And then also, estrogen, pharmacologic estrogen carries a risk of endometrial or uterine neoplasia. And this is due to the fact that it causes endometrial proliferation. Also, pharmacologic estrogen comes with a box warning. And the one that they kind of focus on, at least in second year, is the fact that if you give a patient estrogen replacement without progestin, it can increase the risk of endometrial cancer in women with an intact uterus. So why would women forego like the progestin replacement. So if you have a patient on estrogen replacement and you're like, hey, unless we give you the progestin on top of it, you're going to be at risk of, or an increased risk of endometrial cancer. What is the reason that they might have a tendency to say no to that? Like, no, I don't want the additional progestin replacement. Yeah, progestin. There are like progestin only birth control methods, but we're talking about like a postmenopausal woman. So what I'm getting at is sometimes women don't want to add the progestin replacement to the estrogen replacement, and that this is because they can see breakthrough bleeding with that. So if you give the progestin therapy on top of the estrogen replacement, one of your adverse effects is a risk, or not a risk, like possible breakthrough bleeding. So sometimes, you know, women, for understandable reasons, don't like that idea of adding progestin replacement to their estrogen therapy once they've stopped having periods. Okay, so now our SERMs. So these are the selective estrogen receptor modifiers, and they act as mixed agonists and antagonists. The first one is clomiphene, and it's used in the treatment of infertility. And it's going to selectively block estrogen receptors in the pituitary, which reduces negative feedback and increases FSH and LH output, which would be necessary for ovulation. Um, so it's going to be used to induce ovulation in anovulatory women because it acts as an agonist in the ovaries. However, one of your adverse effects would be the fact that you could see multiple follicles growing. All right, so for these next drugs, what you want to focus on is what are they doing in the bone, what are they doing in the breast, and then what are they doing in the endometrial tissue. So raloxifene, he said to remember kind of as an overhead, it's used to treat the bone in menopause. So it acts as a partial agonist in the bone, and it's approved for prevention and treatment of osteoporosis in postmenopausal women. Um, and it has an antagonist effect in breast tissue. So it's used in the prevention of breast cancer, but not the treatment. And then also an antagonistic effect on endometrial tissue, so you're not going to see an increased risk of endometrial cancer. And then with toramifene, this is used to treat breast cancer in menopause, and it is an estrogen receptor antagonist in the breast, so treatment of metastatic breast cancer in postmenopausal women. And then tamoxifen, in my opinion, is probably most likely to ask you about this one. So tamoxifen, it works because it's an estrogen receptor antagonist in the breast, but it's also an agonist in the endometrium and the bone. So it's used to prevent and treat hormone-responsive breast cancer. It prevents osteoporosis in breast cancer patients as well. But the big problem here is that patients who have been treated with tamoxifen, they're at an increased risk of endometrial cancer because it acts as an agonist in the endometrium. Okay, our selective estrogen receptor downregulators, these are the SERDs, and they act as antagonists. So fulvestrant is a pure estrogen receptor antagonist in all tissues, and it's going to be used to treat women with breast cancer that have developed resistance to tamoxifen. And then, due to the anti-estrogenic effects, you're going to see a risk of osteoporosis. So kind of again, three focuses. What is it doing in the breast? What is it doing in the endometrium? And what is it doing in the bone? Like you should be able to answer those questions for these three drugs. Okay, and then the last one here is anastrozole, and that is an aromatase inhibitor. So aromatase is the last enzyme required in the last step of estrogen synthesis. And this is going to be used for treatment of breast cancer in postmenopausal women. Okay, so a few practice questions. So, 70-year-old male who's diagnosed with metastatic prostate cancer, for which he's prescribed leuprolide acetate. Which medication will you give him to avoid a testosterone flare? Right. So, correct answer is flutamide. The next one, 65-year-old male is diagnosed with BPH. What is the mechanism of action of the most appropriate drug for treatment of his condition? Right. So this is a 5-alpha reductase inhibitor, and what is the name of that drug? Right, finasteride. Okay, so next question. So you've prescribed him finasteride, and you tell him which of the following individuals should not handle his tablets. Right, so pregnant women should not handle finasteride. And then a 35-year-old female is prescribed a drug to treat her estrogen receptor positive breast cancer. Which of the following is she at increased risk for following treatment? Right, endometrial cancer. Because it's an antagonist in the breast and then an agonist in the endometrium. And also an agonist in the bone, so it would be protective of the bone rather than a risk of osteoporosis. Okay, so that same female has now become resistant to tamoxifen. What are you going to prescribe her now? Right, good. So fulvestrant. All right. Now for the pharmacology of glucose and insulin. Is fulvestrant only one we've covered that can cause osteoporosis? I think so. Yeah, I'm trying to double check here. Yeah, but I think of the ones we've covered, that's the only one. I think the rest of them are agonists in the bone. Okay, so with this lecture, like he gave you a ton of information about like combinations of insulin and dosing and just like a lot of stuff that, I really don't think he's going to test you on. He kind of said a couple times, just focus on, is it rapid acting, short, intermediate, or long acting? Which types of insulin fall into that category? And then also have an idea as far as when are they used? Like, are they associated with mealtime? Or are you trying to maintain your basal glucose levels? So I tried really hard to only include stuff in this section that I thought he would actually test you on. So hopefully that helps. Okay, so 4 types of exogenous insulin. You have both rapid and short-acting insulin. And your rapid-acting insulin consists of Lispro, aspart, and glulisine. And then your short-acting insulin is just like your regular run-of-the-mill insulin. So this is Humulin or Novolin. I thought Anastrol caused. Osteoporosis as well. Did he have that in the lecture? Maybe I mean, yeah, it causes an increased risk of fractures, so you may very well be right. I'll double check on that though when we're done. But you're probably right. Okay. Let's see. So your rapid acting insulin, so you're going to administer it just before or up to 15 minutes following a meal. And then your short-acting insulin, it's given 30 minutes before a meal, and both of these are given to mimic the prandial bolus insulin release that's seen like with a nutrient load. It's just a matter of, their duration and when exactly, the patient is taking it. And then your intermediate insulin is your NPH, and this is regular insulin, and then with the addition of zinc and protamine. So when you add the protamine, it's going to delay absorption time, and that's because the protamine has to be cleaved from the insulin in order for absorption to occur. So this is going to increase your risk of hypoglycemia, and it's used for basal control and as well as your long-acting insulin, which is insulin glargine and insulin detamir. And these are your 2 peakless insulins, and they are slower in onset than NPH, so you're going to see less of a risk of hypoglycemic episodes. Okay, so like I said, he gave you a lot of stuff that I don't think you really need to know right now. But this is important. So, who needs injectable insulin? So, anytime your fasting blood glucose is greater than 300, or it can be added to any patient on PO therapy. So, what does that mean? What does he mean by PO therapy? Yeah, by mouth. So, if they're taking, something by mouth to treat their diabetes and they still have a fasting blood glucose of over 250. Also, all of your type 1 diabetics are on injectable insulin, and then your patients with gestational diabetes, so during pregnancy. And your adverse effects of injectable insulin therapy, the two big ones are going to be hypoglycemia and then obesity. So when you use the insulin and beta blockers, you're going to mask the symptoms of hypoglycemia with the exception of one thing. So what is that symptom that you're still going to see? Right, sweating. And why do you still see sweating? Right, it's because of the location of those M receptors on your sweat glands. So your beta blockers are not going to do anything for that, or they're not going to mask that. So you'll still see the sweating. And then also, you have a risk of obesity, and this is because when you're injecting insulin, you're taking the sugar out of the blood, and it's being taken up into the adipocytes and then stored as fat. So what is lipohypertrophy and lipatrophy? Right, and why does that happen? Or where does that happen, should I say? Right at the injection sites. Yeah, exactly. Okay, so I just looked up anastrozole, and it says it does lower bone mineral density, so it increases the risk of a fracture. But whether or not it lowers the density enough to be considered osteoporosis, I'm not really sure. So that'd probably be more of a question for Dr. Quadri, unless he had osteoporosis somewhere on the slide. Which, if he did, let me know. Okay. Now, just a quick mention on C-peptide. So something important to realize is that when you have endogenous insulin production, it produces a molecule of C-peptide with each. Sorry to send you down a rabbit hole. Oh no, it's totally fine. Um, yeah, so if you want to ask him, yeah, it's totally fine. Yeah, and I totally understand. Okay, so C-peptide, yeah. So with each molecule of insulin produced, you're also going to produce a molecule of C-peptide. And then with exogenous insulin, you're not going to see an increase in C-peptide. So I think during the lecture, he told a story of like how this guy killed his wife or something by overdosing her on her injectable insulin, and the way that they found that out is by measuring the C-peptide levels. Oh, and then also I wanted to point out something. So C-peptide can be used to differentiate between type 1 and type 2 diabetes. So why would that be? Or, how could you use C-peptide to differentiate between type 1 and type 2? Yeah, you still make insulin in type 2. It's just your tissues are resistant. Yeah, so no C-peptide in type 1. Yeah, exactly. Okay. Um, Let me catch up with my notes here. Okay, so I just left this how it was in these slides. So if you have a patient who is hyperglycemic or hyperkalemic, insulin, so on this side, insulin is going to bind to the insulin receptor, and then it's going to increase the activity of the sodium, potassium, ATPase, and then potassium is going to move into the cell. So when you measure the serum potassium, you're measuring what's in the blood and not necessarily the total body potassium. And then in a hyperglycemic patient, insulin is going to bind to the insulin receptor. It's going to increase the activity of GLUT4, and then glucose is going to move into the cell. So you'll see hypoglycemia. So the big takeaway here is insulin causes glucose and potassium to shift into skeletal muscle, resulting in hypoglycemia and hypokalemia. Okay, now for all of our anti-diabetic drugs. Okay, so the first group here is going to be your insulin secretagogues. So these are going to increase the production of endogenous insulin. So how are they working? Okay, so your secretagogues are going to inhibit the potassium channel. So if you have less potassium leaving the cell, you're going to see a buildup of potassium within the cell, and that's going to cause the cell to depolarize. And when you get the depolarization, you're going to see the calcium channels open, so an increase in calcium influx, and this results in increase in insulin release. So with secretagogues, because you're increasing endogenous insulin release, you're also going to see an increase in C-peptide. And then your two types here are your sulfonylureas, so chlorpropamide and tolbutamide, and then your second generation is glyburide. And then some important adverse effects are your disulfiram-like effects, and that's by targeting acetaldehyde dehydrogenase. And then hypoglycemia, so it's important to eat on time. And then SIDH, and this is important with chlorpropamide. And then also weight gain. You want to caution in use in hepatic and renal failure due to impaired clearance of the drug. And then your glynides, the one to know he wanted you to know was repaglinide. And this one is taken with meals, so it's important to know that if the patient is going to skip a meal, they need to skip their dose. And then you can also, with this one, see hypoglycemia and weight gain. And your risk of hypoglycemia is increased with renal failure. Okay. Your bigonines, these are going to increase sensitivity of the peripheral tissues to insulin. So a big important one is metformin, and this is kind of your like starter drug for anybody who, like, when your patient is initially diagnosed with type 2 diabetes, most often they're going to be started on metformin. And metformin, one thing, two things actually, that are commonly tested is metformin's mechanism of action, which is kind of unique. So it's going to decrease hepatic glucose production. And then that's its primary mechanism. And then, what do you call the secondary mechanism is the fact that it increases insulin mediated peripheral glucose uptake. So the big one I would know here is the fact that metformin decreases hepatic glucose production. Like I said, it's your initial drug in most type 2 diabetes patients. And then it can also be used for treatment of PCOS, and that's an off-label use. One of your big advantages is the fact that you don't see weight gain, and then metformin is super cheap. So again, like one of the reasons that it's kind of the first thing that they throw at patients. A rare adverse side effect, but one that is very board relevant, is the fact that you can see lactic acidosis with metformin. And this is because metformin is working against pyruvate dehydrogenase. So you're channeling the pyruvate into lactate formation instead of entering the TCA cycle. But this risk, it's rare, but the risk increases with CHF, renal failure, and then especially hepatic dysfunction, also alcohol abuse and sepsis. So if a patient has a GFR of less than 45, you're going to reduce the dose in half, and then you're going to stop the drug if their GFR is less than 30. Okay. Your next group of glycosides are the PPAR gamma agonists. So, for example, pioglitazone. And it's going to enhance the insulin sensitivity at target tissues. And this is its primary action. Its secondary action is its decrease in hepatic gluconeogenesis, which is metformin's primary action. And then the most important adverse effect here is going to be the fact that the PPAR gamma agonists are going to increase your extracellular fluid volume, and this is by increasing the activity of the ENaC channel, which leads to edema. So one of your contraindications are going to be giving a patient with CHF pioglitazone, because it's going to worsen their heart failure. And then especially a patient on insulin, if you add the PPAR gamma agonists, both of these are increasing the ENaC channel. So more edema, more heart failure, which is, of course, a bad thing. Okay, so 3 more. The first one is your alpha glucosidase inhibitor, which is acarbose, and this is going to decrease absorption of dietary glucose by inhibiting alpha glucosidase. So it's going to decrease the digestion of complex carbs. So he mentioned, it was like in the management, it was a slide about the management of hypoglycemia. He talked about how you should make sure that if a patient has hypoglycemia from being on acarbose, that you wanted to give them dextrose rather than sucrose. And this is because sucrose is complex. So if you give something like sucrose and you have acarbose on board, the inhibition of alpha glucosidase is going to prevent that sucrose from being broken down into a simple sugar. So instead of sucrose, you're going to give something like dextrose which is structurally similar to glucose, or just give them like a couple of glucose tablets. Okay. The next one, your GLP-1 receptor agonist. So exenatide. Exenatide is going to increase postprandial insulin release and suppress glucagon release, which decreases blood glucose. And let's see. One of your big advantages here is weight loss. So this is one of the few anti-diabetic drugs that are actually going to promote weight loss, I think. Because with metformin, you're not at risk of weight gain, but it's not necessarily helping patients lose weight. So exenatide, and another one that you see commercials for a lot is liraglutide, which is Saxenda. Sometimes those are given sort of like, I guess, sort of off-label to patients who want to lose weight, but who are, already at risk of diabetes or metabolic syndrome due to their obesity. So this is a good one for a patient who is both diabetic and obese, because promoting weight loss. And then one of your important drug interactions are your DPP-4 inhibitors, which increase risk of pancreatitis. And so how is that happening? How does that work? Right, so what are DPP-4 inhibitors preventing? The breakdown of what? Right, GLP-1. So DPP-4 prevents the breakdown of GLP-1, which increases the number of beta cells, leading to pancreatitis, possibly. Okay, and then your DPP-4 inhibitors, the two to know are sitagliptin and saxagliptin. And then what we just talked about, they inhibit DPP-4 and increase circulating levels of GLP-1, which increases insulin concentration and decreases glucagon. Okay, that's the most important stuff. All right, next are your SGLT2 inhibitors, which increase glucose excretion in the urine. And the one to know is canagliflozin. So its mechanism of action is it's a sodium glucose cotransporter inhibitor. So it's going to decrease the reabsorption of glucose in the proximal tubule. And because of that, you're going to increase urinary excretion of glucose. So, you're not seeing that reabsorption into the proximal tubule. So you're going to eliminate it through the urine, and then you don't have the reabsorption of glucose through GLUT2, and you see a decrease in blood glucose. This one's used for type 2 diabetes. And then two important adverse effects are hypovolemia and hypotension, because when you get rid of the sodium, water follows. And then hyperkalemia, I think they're not totally sure the mechanism. I know one that he discussed in lecture was that they think it affects the sodium potassium ATPase pump over here. Then you also want to avoid canagliflozin in renal failure. All right, so management of hypoglycemia. You want to treat all blood glucose levels less than 70, so important to know. And then also the one I was talking about, if a patient is on an alpha glucosidase inhibitor, you want to give them dextrose and not sucrose because sucrose is complex. So if you're giving someone sucrose and you have an alpha glucosidase inhibitor on board, it's not going to be broken down into a simple sugar. So it's better to give them dextrose, which is similar to glucose, or a couple glucose tablets. So yeah, especially in a patient on an alpha glucosidase inhibitor. Let's see. The other two that I would know are that if you have a patient who's unconscious, you're going to want to give glucagon or IV glucose. And then the whole idea that you're compromising hypoglycemic awareness in a patient using insulin who's also on a beta blocker because you're masking the symptoms of hypoglycemia, and the only thing that they're going to see is sweating. So that would be something that you would want to inform your patient of. Okay, and then he had, so after he talked about canagliflozin, he had a couple more drugs, but I would consider them much lower yield, especially if you're in a situation where you're more worried about neuro. So I'm not saying don't know them, I would just know what I have on these slides first. Okay, and then the last slide here. Okay, so we talked about the management of hyperglycemia, and the two important drugs are octreotide, and then he made the comment that he really wanted you to focus on this one, which is diazoxide, and it's used in treatment of insulinomas or sulfonylurea overdose. And that's because, if you go back to the slide that talked about sulfonylureas, the mechanism of action of this drug is more or less the opposite of what you see in sulfonylureas. So diazoxide is going to open the potassium channel rather than close it. And the beta cell is going to hyperpolarize because you're losing positive charge. And you're going to see a decrease in calcium influx and then a decrease in insulin release. Yeah. Okay. So which of the following might you expect to see in a patient taking an insulin secretagogue? Right, so correct answer is C, an increase in C-peptide. And this is because your secretagogues are increasing the production of endogenous insulin. So with an increase in production of endogenous insulin, you also see an increase in C-peptide, whereas if you had exogenous insulin, you would not see an increase in C-peptide. And then also, rather than obviously not hyperglycemia, because you're giving insulin, you're going to see hypoglycemia because of decrease in glucose, and then your secretagogues, you're at a increased risk of weight gain rather than weight loss. And then you're not going to see hyperkalemia because it's the drug's mechanism of action is that it blocks the potassium channel. So in order for it to work, you block the potassium channel and you see an increase in potassium within the cell in order to depolarize the beta cell. So you actually see less potassium leaking out into the blood. All right. So a patient recently diagnosed with type 2 diabetes is prescribed a drug that decreases hepatic glucose production. If the patient develops congestive heart failure, use of this drug will be contraindicated due to increased risk of which of the following? Right, so the correct answer is C, so make sure that you associate metformin with lactic acidosis. All right, a 60-year-old male patient presents to the emergency department with a blood glucose of 68. He is tachycardic and diaphoretic. He takes a medication at mealtime that inhibits alpha glucosidase. His wife is afraid that he may have taken too much. Which of the following is not an appropriate treatment for this patient? Right, so sucrose. The other three are simple sugars, so you want to make sure that you're not giving something complex because acarbose is an alpha glucosidase inhibitor, and you're not going to see the breakdown of those complex sugars. All right, one more. So the pharmacology of antivirals. All right, so your anti-herpes virus agents, the first one that she talked about was docosahexaenol. So docosahexaenol is a fusion inhibitor, and it prevents entry into the cells and subsequent replication. And this is used in HSV1, so your oral herpes, and it's used to treat herpes labialis, which is referring to cold sores or fever blisters. And you're supposed to apply within 12 hours of prodromal symptoms 5 times daily. This one I would call more low yield because, most people are just going to ride it out with a cold sore and not pay for an expensive medication. Okay. Next is acyclovir, and this is a really important one. So during first pass metabolism, valcyclovir is converted to acyclovir, and then famciclovir is converted to penciclovir. And you have both oral and IV. I believe she mentioned that you don't need to know the difference between what oral treats versus what IV treats. So, just know in general what acyclovir treats. So the two big things would be genital herpes and then adult varicella zoster. And then also IV for herpes simplex encephalitis, neonatal herpes, or serious herpes infections. So if it helps, maybe kind of remember oral acyclovir for just your standard genital herpes or varicella, and then your more severe complications, you're going to use IV acyclovir. She pointed out that one of your important adverse effects are the fact that it's nephrotoxic, so you want to make sure that you're not combining this with other nephrotoxic drugs. And then the big thing from this slide is that acyclovir is dependent on phosphorylation intracellularly by viral kinase, and then subsequently by host cell enzymes to become inhibitors of viral DNA synthesis. So if the virus doesn't want to cooperate, you can see resistance to acyclovir, and this is due to things like impaired viral thymidine kinase, altered thymidine kinase substrate specificity, and then altered viral DNA polymerase. Your second one that is dependent on phosphorylation by viral kinase would be ganciclovir. So it works by inhibiting viral DNA synthesis. And then in HSV, it's going to be phosphorylated by viral thymidine kinase. And then in CMV, so cytomegalovirus, it's phosphorylated by viral phosphotransferase. And then again, so you can see GAN-cyclovir resistance either through reduced intracellular phosphorylation or mutations in viral DNA polymerase. And the big ones used to treat is cytomegalovirus. You can see myelosuppression and neutropenia. And then these two, so cidofovir and foscarnet, phosphorylation of these medications is independent of viral enzyme. So that's important that both these drugs, you can see activation without phosphorylation by the virus. So resistance is less likely to develop. The one I remember, one adverse effect I remember with cidofovir is that you want to administer it with probenecid, and this is due to the fact that it is nephrotoxic. So if you administer cidofovir with probenecid, you're going to block active tubular secretion and decrease nephrotoxicity. And then again, foscarnet is also nephrotoxic, which you can prevent with the saline preloading. But you definitely have probenecid in red. So, and this is kind of unique. So you give cidofovir, give probenecid to prevent nephrotoxicity. I could definitely see that being a test question. Okay, your drug for influenza is going to be oseltamivir, and this is a neuraminidase inhibitor. So know the mechanism of action, and it's used in the treatment of influenza A and B. However, it's crucial that you give this drug early on. So a lot of times people with flu-like symptoms, they might feel terrible for a week and, wait a week before going to the doctor. And then, at that point, there's really nothing that you can do for them because in order to give them Tamiflu, it would have had to be been given within the first 24 to 72 hours after onset of the illness. And then also important to know is the fact that you can give a Tamiflu to family members as a means of prophylaxis in those who have been exposed. So if you have a parent bringing a child who tests positive for influenza, you can also prescribe that parent Tamiflu. All right, your hepatitis B treatments are adofovir and telbivudine, and then entecavir. I did a lot of condensing here. She had these on 3 separate slides, but I don't know if you noticed, but these two actually have the same mechanism of action. So they're going to inhibit DNA, hepatitis B DNA polymerase and reverse transcriptase, resulting in chain termination. And then entecavir is going to inhibit all 3 functions of hepatitis B DNA polymerase. And they all have the same adverse effects. The one to know would be an acute exacerbation after hepatitis or of hepatitis B upon discontinuation. So these are lifelong drugs because it's a chronic infection. So if suddenly the patient stops taking it, like a common example would be, they lost their job, so they lost their insurance, then they can see, exacerbation of their hepatitis B. Okay, so your pegylated interferons. So you have pegylated interferon alpha 2 and then 2B. You need to know that 2 is treating hepatitis B and C, while 2B is only approved for treatment of hepatitis C. And the use of pegylated interferons versus just interferon therapy, it has a slower clearance, a longer half-life, and steadier concentration. So it's advantageous because the patient has to take it less frequently. So you have less frequent dosing. Okay, then ribavirin. This is used in combination therapy with interferon in the treatment of hepatitis C, or it can be used as an aerosol in the treatment of RSV. And the big important adverse effect is the fact that it's extremely toxic. So if you have a patient who is taking ribavirin, they should not try to conceive a child until at least 6 months after they've stopped the medication. And then also, healthcare workers can experience adverse effects by being exposed to ribavirin, and this includes things like headache, conjunctivitis, rhinitis, nausea, and rash. And from what I read, this is most common in the aerosolized form of ribavirin. Okay, so the point here is that if you have a patient with hepatitis C who has been infected with hepatitis B in the past, it's important to know that because when you treat their hepatitis C, you can see a reactivation of their hepatitis B. And this can manifest through symptoms like fatigue, weakness, loss of appetite, nausea and vomiting, yellow eyes or skin, light colored stools, etc. So if you have a patient with a hepatitis C and hepatitis B co-infection, it would be very important to monitor them when you're using a direct-acting antiviral. Or, if it's the first time you're seeing them and, they're seeking treatment for hepatitis C, make sure you ask them if they have a history of hepatitis B. Okay, so examples of your direct-acting antivirals, your protease NS3 and N4 inhibitors, so like Cimeprevir. And these are used in combination with PEG interferon and ribavirin. And that's because if you don't use them in combination therapy, then you can develop resistance if you're trying to use it as monotherapy. And these are both inhibitors and substrates of CYP3A4. And then your NS5A inhibitors are your ASVIRs, so daclazivir, ledipasvir, and ombitasvir. And the way to remember these, if you turn the AS, if you flip it over and reverse the letters, it looks like 5A. If you use your imagination, so if you could see like a 5 instead of S and then an A there, that's one way to remember those. And then finally, your nucleotide polymerase inhibitors. This would be sofosbuvir. And make sure you know that it's not recommended that you give it with amiodarone, and that's due to the symptomatic bradycardia that you might see. Okay, and then last one, it would be ritonavir. And this is your protease inhibitor used in the treatment of HIV, and it's a strong CYP3A4 inhibitor. So the reason that is important is because if you have a drug that's metabolized by CYP3A4 and you give someone a CYP3A4 inhibitor, then you can see increased levels of the drug that is metabolized by CYP3A4, which could, of course, could have any number of adverse effects. Okay, so we have a 9-year-old female who presents to the urgent care with fever, malaise, myalgias, cough, and rhinorrhea. Her mom states that her daughter's symptoms started 4 days ago. Rapid flu testing is positive for influenza A. What is the most appropriate next step in treatment? Right, so the correct answer here is C, to tell the mom that her daughter needs basically just supportive care, so rest and hydration. And that's because since the symptoms started 4 days ago, it would be too late at this point to prescribe either of them oseltamivir. Okay, so you have a nurse that presents to the. But wait, but I thought you could use it as prophylaxis. Um, I was under the understanding that if the exposure um, had been several days, that maybe you couldn't, but I could be wrong. I will look that up though and make sure before we get done here tonight. Okay, so you have a nurse presenting to the ED with headache, conjunctivitis, rhinitis, nausea, and rash. You ask her when her symptoms started, and she replies a few hours after giving a patient aerosolized treatment for RSV. Which drug did she give the patient? Right, so correct answer is ribavirin. So, just remember your exposure and healthcare workers to that drug. All right, so you have a 40-year-old male patient taking a direct acting antiviral for his hepatitis C infection who presents to the clinic with fatigue, weakness, loss of appetite, nausea and vomiting, jaundice, scleral icterus, and light colored stools. You tell the patient his symptoms are likely the result of reactivation of which of the following? Right. Right, so the correct answer there would be hepatitis B. Okay, just looking up real quick about the Tamiflu. If anyone happens to know from personal experience, let me know. She says replication peaks at 24 to 72 hours after onset, and once daily prophylaxis can prevent after exposure. Daughter got the Tamiflu instead, but I don't know. Okay, hold on. I think I may have found something here. Okay, so I found a link that said that Tamiflu and said the drug insert for Tamiflu indicates post-exposure prophylaxis should be begun within 2 days of exposure. Uh, but I don't know. If she said that there's no time limit on um, taking it after exposure, then yeah, I mean, for sure, trust her. All right, does anyone have any other questions? Yeah, you're welcome. And I'll email and ask her just so like we can have some clarity on that, like what exactly is the time frame after exposure that you can take it. Otherwise, if nobody has any questions, good luck studying. Hope you guys have a good night.